Thank you so much, Kish. And it's both a pleasure and intimidating to speak after Susan. I think we can all agree that was just an amazing tour de force on the inner ears and just shows how, when we make it our focus, the level of detail that we can actually demonstrate antenatally. I'm going to take you a step back now to one of the more basic indications for fetal MRI. It's still the most common indication in my practice for fetal neuro MRI, and it's the assessment of a fetal ventriculomegaly. I have no disclosures, and as we're running a little bit behind time, I have cut some of my later slides just to hopefully get us a little bit back on track in terms of the schedule. So as we go through this discussion together today, I have taken the fetus with spina bifida as a unifying theme throughout the talk, and quite a few of the cases that I will show you will have that background. And so let's start with just a few definitions. So as I've said, that's picked up on antenatal sonography, and just a few definitions because it is important that we are quite tight in our terminology. When we refer to ventriculomegaly, we mean that there is an excess of CSF within the ventricles in the brain. And when we use the term hydrocephalus, we're implying that there's increased CSF pressure, and that's usually associated with increased head circumference. We are very particular about where we take our measurements. We measure at the atrium of the lateral ventricle, and the reason we do this is because the size and configuration at the atrium is stable during the second and third trimester, which corresponds to the majority of the time when we will be assessing with fetal MRI. And if we look at the means, the mean is 7.6 millimeters between 14 and 38 weeks. And by the time we get to 10 millimeters, we're already between 2.5 and 4 standard deviations above the mean. Male fetuses, for whatever reason, just tend to run a little bit larger. So, a borderline ventriculomegaly, a little bit less significant in a boy than in a female fetus. We further characterize ventriculomegaly then between mild, which is 10 to 12 millimeters, moderate 12 to 15, and severe over 15. And this is important because the prognostication and the outcomes is very much linked to the degree of dilatation. And most fetuses, over 91% of fetuses who are in that mild category, will have a normal neurological outcome. But some of them, there is an increased likelihood of ADHD and some neurodevelopmental variants later on in school. But when we're in that severe category, when we're above 15 millimeters, we're much more likely to have an underlying neurotropic infection or a chromosomal or a genetic cause. That moderate group in between, we have is probably the hardest group to counsel because there's such heterogeneity in terms of the clinical outcomes, and it really does depend on the associated pathology. We've already had a wonderful lecture from Camilo on protocols, so I won't dwell on this, but just to say that for ventriculomegaly, as for most fetal indications, single shot fast spin echo and steady state reprecession sequences in all three orthogonal planes are the workhorse sequences that we get most of our diagnostic information from. The T1 is important, and there's a case that I'm going to show you later where it was really helpful. In my practice, we do a Cine Fiesta swallowing sequences on all fetuses. We find it very useful for assessment of the palate. Our colleagues, our MFM and midwife sonographer colleagues who perform ultrasound here in Ireland are really good at assessing the palate on ultrasound, but we find this a very helpful addition. And of course, it's very good for midline and other structures. It's nice to have a dynamic sequence. So a very common scenario for us is a fetus that's somewhere around 22 to 26 weeks who's been referred with mild fetal ventriculomegaly, looking for MRI to confirm, because of course it can be challenging on ultrasound depending on the position of the fetus to get really accurate measurements. And so MRI is really helpful to confirm either normality or the presence of ventriculomegaly, and of course to look for additional findings. And a key thing that I'll be emphasizing throughout this presentation is once we have identified fetal ventriculomegaly, not to get satisfaction of search, but to be really methodological in our approach. So feel free to take screenshots of any of these that you would find helpful in your practice. And as I think Kish said, we're hoping to make these presentations available to people afterwards, because of course, it is very good to be able to come back in your own time to focus on specific things. So this is a broad list of things to look for. So Associated callosal dysgenesis or agenesis of the corpus callosum is very commonly associated with ventriculomegaly and probably is the most common additional finding that I have in my practice in the setting of ventriculomegaly. I like to describe searching for grey matter heterotopia as being very similar to a fracture search in pediatrics. So really important to trace that ventricular lining very carefully and look for those subtle foci. If we have ventriculomegaly in a male fetus, we're always looking to see how can we help our perinatal genetics colleagues, what features might indicate potential genetic etiology. And if we have lateral and third ventriculomegaly in a male fetus, and we're thinking about aqueductal stenosis as a pathology, keep X-linked L1 CAM in your mindset as something to consider. Neurotropic infections are really important. So looking for associated MRI findings. Are there any septations? Have we correlated with the serology? And of course, we have our developmental malformative process, such as muscle-like brain disease, and Walker-Warburg is probably the one that most of us will have seen a few times in clinical practice. And of course, with the fetus, while we may be focused on the brain for this indication, it's really important that we look at all of the fetus that's imaged and look outside the brain for clues that might help us with a genetic diagnosis that ties everything together. So again, some review areas that are helpful. A really good place to start with the fetus is that most fetuses are normal, and normal fetuses look very similar to fetuses of a similar gestation. So after I have measured all my biometry and compared with means for gestation, one of the first questions I ask myself is this sulcal gyral pattern gestationally appropriate? And I think I'm 10 years practicing now in fetal MRI, so I have a good internal biometry of what a 26-week fetus looks like, what a 28-week fetal patient looks like. But when you're starting out and when this is new to you, there's lots of online and paper resources that are really helpful. So Beth and Dorothy's book, the second edition, which I have referenced here, has really, really good gestational norms. And then there's also the website fetalmri.org and others that have each week coronal, axial and sagittal what the appropriate gyration pattern is. So until you've seen enough that you're very comfortable with what's normal at 22, what's normal at 24, do lean on these resources because they really will help you. So these are my check areas when I'm on my axial sequences. I interrogate the globes looking for a coloboma, and I have a case that I'll be showing you in a few minutes that illustrates that. I interrogate the corpus callosum first to see is it present, then to see is it complete, or is there any element of callosal dysgenesis. And it's important not to forget the structures of the face, the bones like the maxilla and the mandible, because of course we can have pathologies that will unite both. On the coronal sequence, again, really important, the eyelids, the globes, the lips, the palate. I mentioned earlier, we have a nice cine dynamic Fiesta sequence that we use for assessing the palate. And most of the time, the fetus is helpful and will have opened their mouth. And so the amniotic fluid will nicely outline that primary and secondary palate. On the sagittal view, again, that facial profile, really interrogating that mandible very carefully so that we don't miss either micrognathia or retrognathia. And then, other subtle areas, the ears, looking for symmetry, position, because again, in the setting of a genetic fetus, often the ears can be a clue to an underlying associated pathology. And I've mentioned this before, but it is so important to look at all the solid organs, to look at the spine and the hands and the feet for those clues that might push us in the same direction. I think I've actually covered this already, but just the importance of comparing with gestational norms, because normal fetuses will look very similar to fetuses of the same gestation. So now you've been very patient as we've worked through some of the theory to show some cases. So as we know, the corpus callosum is one of the major commissures that connects the cerebral hemispheres. And it can be tricky on ultrasound, especially at a more advanced gestational age, to confirm that it is completely present. So MRI with our orthogonal planes can be really helpful. And there's various signs that we refer to. So when we have agenesis of the corpus callosum, we get this paralleling appearance of the lateral ventricles, often with associated colpocephaly, this prominence of the occipital horns. And then this appearance on the coronal of the frontal horns in the setting of an absent corpus callosum. I love how many different animal names there are for it. So some people refer to it as the moose head sign. It's also called the steer horn sign. If you want to be specific and be, Texas Longhorn, then there's also buffalo horn trident. So there's so many different names for it, but this is that really a classic appearance. So it's generally, when there's complete agenesis, it's a pretty straightforward diagnosis on MRI. But if there's a partial agenesis, that can be a bit more subtle. And again, that's where comparing with our norms and seeing where our biometry and then that subjective appearance comes into it. So this is another case that was referred with agenesis of the corpus callosum. In this case is courtesy of a colleague and friend of mine, Mariana Myers, who I believe you're seeing later on the panel. And so this again, so another case of agenesis of the corpus callosum, very similar. And this is the problem that we can face in fetal. So if they're, when we made a diagnosis, just not to stop at that, but keep scrutinizing those review areas. You can appreciate on the axial view and also on the sagittal that there's a subtle coloboma present. And so ultimately a diagnosis of acardie was made in this patient, but this is a subtle finding that in the midst of looking at 800 or 900 images in a fetal study can easily be missed. So just add it to your review areas that you always scrutinize the globes, because every so often you're going to pick this up and it's going to help with our perinatal genetics colleagues and their management of our shared patients. As I mentioned before, when we're looking for heterotopia, scrutinize the lining the same way you would trace the outline of a bone looking for a fracture. I think here, when I compare the fetal study with the postnatal study, that the heterotopia is just as obvious on the fetal scan as it is on the postnatal scan, which was done to confirm. But sometimes this can be very subtle, so scrutinize in every plane and compare, because all of this information will help our MFM and our perinatal genetics colleagues. I mentioned aqueductal stenosis earlier. This was a male fetus referred to us in the 3rd trimester. You can appreciate that severe bilateral ventriculomegaly, and this ended up being L1 CAM, X-linked hydrocephalus. This is another patient with ventriculomegaly, and this also perisylvian polymicrogyria in the setting of a molar tooth appearance, and this patient ended up having Joubert's. In terms of review areas, it's really important to look at the white matter. This is a really obvious case where there's really florid white matter T2 signal hyperintensity, but sometimes it can be more subtle. This case ended up being a very severe case of CMV. I mentioned malformative development diseases such as muscle-eye brain disease. This was one of my earliest cases when I started in practice in Ireland. And this patient was referred with severe ventriculomegaly and had that classic Z-shaped appearance of the mesencephalic junction. And this ended up being Walker-Warburg's, and I think was the first time there had been an antenatal diagnosis of Walker-Warburg's in Ireland. So it's a case that stays with me. I've mentioned the importance of looking outside the head, looking at the feet, looking at the ears. So this was a patient who had rocker bottom feet, and post interruption of pregnancy, this ended up being a very large deletion on the long arm of chromosome 1 that had caused a significant chromosomal imbalance. But again, seeing these rocker bottom feet, we're not going to pick up on radiology, oh, this is likely going to be chromosome 1. It's not going to be pathognomic in terms of the imaging appearance. But when we see rocker bottom feet, it adds into that picture that this is a patient who really needs to see genetics. One of the things that can be really hard, I find, on fetal is picking up what's not there. And so that's why having review areas and checklists are really important. So we've just had a wonderful talk on from Susan. So, but to bring this back, in this case, you can see here a normal appearance of the external ear here, and then you'll have to trust me that if you scroll up and down, there was nothing here, but there is a small little dysplastic nubbin of the pinna there anteriorly, and that was confirmed at postmortem. This is that same patient with the rocker bottom feet that was confirmed to be a very large deletion on the long arm of chromosome 1. So I said I was going to keep spina bifida as a combining theme throughout this talk. So this was a patient referred to us for consideration for antenatal surgery. And so in Ireland, currently, any of our patients that are considering in utero intervention go to Leuven for surgery, and we do a pre and a post study for them. So you can appreciate a very large open neural tube defect, severe kyphosis. There's a occipital defect here, ventriculomegaly. When we did our T1, because we always will do a T1 on these patients, it was notable for the fact that we had no normal meconium signal in the rectum. And then when I was scrutinizing this and comparing it with the T2, there were all these little T2 hypointensities within the rectum that were concerning for fecalates. So this raised concern for us that this fetus, in addition to having a severe spina bifida, also potentially had a cloacal or UG sinus malformation. So in a female patient, either potentially a rectovaginal or a rectovesical fistula. And we were concerned then potentially about also an imperforate anus. So this was an important diagnosis to make antenatally, because it meant that the parents were counselled by both general surgery and neurosurgery, and the perinatal period could be planned for, because of course with an extensive spina bifida like this, those babies will usually be nursed prone, but for this baby that would have been very challenging. And all of this was confirmed postnatally, and this baby has actually done very well and has had postnatal repairs for both. But it's just a reminder of that importance of the T1, and even when we're doing fetal MRI for neuro indications, it is really important that after 19 weeks, we see that there's normal meconium in the rectum. By 19 weeks, it should be there. And if it's not, we have to think why not, and think for associated pathologies. So staying on this theme of spina bifida, this is another baby that was referred to us with a query for antenatal surgery. So again, you can appreciate our very small posterior fossa, our Chiari-2, our ventriculomegaly. This is our appearance of the spine. Again, you can appreciate the open neural tube defect, unfortunately, because it's right up against the wall of the uterus. It's not as nicely delineated. This MRI was done at 25 and 1. The patient went to Leuven and had a repair the following week. And this is what the patient's posterior fossa looked like just 5 weeks later. So it still looks dysplastic, but you can appreciate now it's much more normal. We have much more space, the CSF around that cerebellum, where previously we didn't. And this is the appearance at the closure site. So sometimes we'll see a little bit of signal dropout or susceptibility artifact related to the surgical material. But it's great to see the improvement in that posterior fossa over such a short period of time. This is another spina bifida patient, very similar, 23+1, that little bit earlier. Our Chiari-2, our ventriculomegaly, and again, a very extensive lumbosacral defect. This is the post-repair MRI, so 7 weeks later. And again, you can appreciate, the posterior fossa. You would know, looking at this without any clinical information, that this is, not a normal appearing posterior fossa, but much improved now, and no Chiari-2. Again, you can appreciate some susceptibility related to the repair. So hopefully I'll have kept my promise to Kish and got us back on track for time. But just to summarize, so fetal ventriculomegaly, it's one of our most common referrals, but we should never get complacent about it. We can bring a huge amount of added value. Before we start, there's a really important piece of workup, looking at all the clinical and ultrasound information that's available to us. Before we start, making sure that patient is comfortable. If they're not, don't be afraid to relocalize until we're happy with the coil position, because it's much harder to try to recover it if we don't just move the coil and get them comfortable. Getting our orthogonal planes, so making sure our patient is comfortable so they can comply and that we can get the best images possible. And then once we have acquired our protocol, comparing that with our gestational norms. And until you're very comfortable with it, there are so many resources there to support us with that. When you've confirmed the diagnosis of ventriculomegaly, just make that list of review areas that you look at on your axial, your coronal, and your sagittal to try and maximize the added value. And one of the key questions I always ask myself when I'm looking at a very abnormal brain is this a brain that has experienced severe injury, the term encephaloplastic covers so much, because it could be ischemic, it could be infectious, it could be traumatic, or is this a process that was malformative? And I find that often really helps me to hone in on which diagnostic path I should be focusing my attention on. And I think the key thing for fetal is that all of us, no matter how many years we're doing it, it's always advancing. There are always new sequences, improvements, the resolution, the diagnosis that we can make now are so much better even than what we could do 10 years ago. And so this community that we have of fetal imagers where we come together, we share cases and we present, it helps us to elevate care everywhere. And thank you so much to Kish and to the team at Spin and at ASPNR and everybody who has supported this. It's wonderful to see over 360 people online on a Wednesday afternoon all around the world learning together. And this is how we shift the dial on prenatal imaging. So thank you so much. This is my email. I'm very happy to take questions in the chat or to have contact by email. So thank you so much.